When the idea of presentation was introduced, the purpose was to get together people and introduce the areas, the common areas that we have in research. So I'm not going through the depth and breadth of what have I done methodologic-wise and so many other things. The purpose is to introduce my work to some of you, and hopefully we'll get some people to collaborate in future. That is the purpose. So I have a lot of slides, but I'm not going to present it, but probably I'll share the slides for the further reading. If you are interested, we can have a chat for discussion. So my name is Mehrshad. I am an economist. My background was studying economics and economic evaluation. And economics can be linked to many areas, all areas of work. Every day we are dealing with money, with time, with limitations, resources, financial, so many other things. So it is important to know the background economic of the things. So what is economic evaluation? When we say health economics, it should be different from economic evaluation. Economic evaluation is a systematic approach of comparing cost and benefit of alternatives. When I say cost, doesn't really mean money, time, opportunities, investment. Research is type of cost. Nothing in this world is free. Even the time that your friend invites you to a free meal, you have to spend time to go to enjoy that free meal. Why we use it? Because allocated limited of resources increase efficiency, and we are always talking about efficiency. There are various types of evaluations. Cost effectiveness, cost consequences, cost minimization, cost utility, cost benefit. You can see a lot of costs here because cost is important. Cost is something that measures the efficiency. Each one of these has complex mathematical equations, which I'm not going through it, but based on the research, each one of them comes in handy when somebody needs to do research. In any type of research activities that you are doing, economic evaluation is part of it. I collaborated with psychology department, I collaborated with health department, international businesses. I have collaborated with law departments, evaluating different variations, programs, etc. Why health economics is under the umbrella of economic evaluation? Health economics is one of the examples of economic evaluation. We are facing rising healthcare costs, limited budget of NHS, ambulances, staffs, nurses, doctors, etc. Need for equitable resource of allocation, and it is very good for decision making, evaluating new treatment, and intervention. When we say intervention in terms of health, you are thinking about drugs, but intervention can be isolating a building to heat not to escape. That is an intervention. Anything that implemented, it's called intervention in our world. So evaluating treatment. This is one example of the research that we did in 2023. That was £500,000 project. It was not, I was part of it. I was a small portion of it. I didn't do the whole project, but it's about community first responders' role in current and future rural workforce. This is the logo of COHRO. It's Community and Health Research Unit. Previously, Professor Nero was leading it, and that is NIHR funder, the external funder that, as you can see, it's a big thing. I was just tiny name here. So the rest of the team did the work. I didn't do the rest of it, but I just part of the economic evaluation. So who are these community first responders? Community first responders, that was only in Lincolnshire. These are volunteers, they don't receive money, that they do trainings by emergency medical staff, EMAS, and they are based on, they work with charities, ambulance services, and they will go, their role is to go first before ambulance arrives. So that they are existing inside the community. The role is very important because when we are comparing in rural and urban areas, particularly the isolated areas where there is no development, they can act faster. We evaluate what they do, where they go, how effective they are, and how much does it cost, how they perceived by service users, and how they develop. We considered 6 ambulance services during 2023, about 4.5 million attendance. Descriptive statistics and other type of statistical analysis were behind this project. When somebody calls the ambulance services, 999 particularly, you will be evaluated on the phone based on 5 categories. Basically, majority of the time, 4 categories. One being the highest priority. So if somebody having a cardiac arrest, that's the first priority. It's number 1. And they will go faster. So we are considering these 2 as very critical points. And you can compare the rural and urban areas. Urban areas are higher. Okay, automatically went there. CFR, more than twice as likely to attend the first on the scene. They attend category 1, 2, and then cardio, respiratory responses are very critical. I have a question. Where do you think in the world, if someone get a cardiac arrest attack, the chances of survival is highest? Which part of the world?
The city?
It's in the city, yes.
Hospitals?
No. You cannot guess. It's in the middle of the desert. It's called Las Vegas. People gambling. There are so many cameras recording it. If they get heart attack, they can see, they come, and then and the chances of survival is high. So you can see why I bring this up, because it's very critical and it is important. What is important? Cost, which is equal time here. The cost is time. This is the differences in response time. There were scenarios that in Lincolnshire, the counselor's mother fell and there was no ambulances, and she left 24 hours without any medical. I don't know if you have known the news. So these are being very critical cases. So CFR introduced, beside as these community first responder services, to help ambulance services. They're not only going for the critical scenarios, but people, elderly people, when they fall, they need someone to take them, to put them on the bed, take care of them. So the service called False Response Partnership, that is partnering with ambulance services. LIVES and EMAS ensure safe health and social care responses to people, and they have 2 types of vehicles they attend. I'm not going through the text, sorry. There are 2 types of vehicles that they attend when these emergency cases happen. So, in Lincolnshire, you might have seen these vehicles even we have, beside the art school, there is a vehicle that they have training. Behind the car, it says lives. These are working in Lincolnshire, and these are ambulances. The differences between these two cars is that they have the capacity to convey the patient to hospital, and the ambulance services can convey them. Life responders, they cannot convey. They just go there to perform the critical scenario. So I am not artist, but I tried to create a very complex like a diagram of what is happening. So somebody calls the ambulance. They pick up the phone. There is an alarm time from the time that the time resource is allocated, time that they will call the ambulance services, call their first responders, travel time, they arrive, they do some decisions, they want backup or they don't want backup, and they left the episode, the scene, time that they arrive to hospital, they leave and clear. That is the whole scenario. The optimum level is not in all of this area, it's only in this area. When somebody falls, the first responder will go, they don't need any backup, they can treat the patient, dispatch, and then they discharge the patient on the scene. There is a cost saving here, which means the ambulance will not go. We estimated the cost is about 738 pounds per triage, per dispatch. The optimum case happens, this is the average time, it's about 25 versus 28, and it's about 2090 episodes, 2090 episodes. You can divide it into that. We can also take a look at the maps where this happened. You can see most of it is in Lincoln. And these are, for example, these are the type of vehicles. The green one is type of lives responders vehicles, and the red one, blue one. So there are three colors here. The green one, the green dots are rural, and the yellow ones are urban areas. Here, the call has happened. They went to an episode. It was not a fall. It was something else. So we have to differentiate between these because the cost is different. And this is based on the severity of the categories. How about the cost? If they go, they don't need backup. They cost about 195 pounds. If with the backup, it's 439 for each episode. And there is a protocol. They need to go there. They find the patient. They need the backup. They call. The backup will go. Sometimes they don't follow the protocol because several times the patient bystander will call and then it will raise the category. So that's why sometimes they don't follow the protocol. These are estimations of the cost for hospitals, standard cares, ambulances. So you can see the cost of CFR is way below. Yeah. So there is element of cost saving. However, there is a cost, another cost, which means they cannot do any benefit when cardiac arrest happens. When the very highly emergency cases where multi-seconds of time matters, false responders or community first responders, they cannot benefit the patient. They can benefit the patients when it's not in the highest priority. So there is no clear benefit of out-of-hospital cardiac arrest, but false respondents, there was cost saving and they have benefit. We have some publications based on this research, and I am happy to answer any questions and also collaborations in future. Thank you.